Good afternoon. My name is Dr. William Morris, Executive Medical Director of Cleveland Clinic Innovations and Ventures, and it is an absolute pleasure to welcome you all to our second tremendous panel for Transformation Tuesdays. Today, we're talking about the digital doctor's office. We all know the power and the vision of telehealth, and certainly in times of COVID, what that platform and experience can do for both the providers, the health system, and patients. But what does the doctor office of the future look like? How does the physicality and the distance be solved with innovative tools in the diagnosis and management of these complex patients? And certainly, at the end of the day, create those intimate, valuable experiences. Well, today we have a panel led by Dr. Adam Myers, my clinical boss, who is Chief of Population Health and our Cleveland Clinic Community Care. Please welcome Dr. Adam Myers and his lovely panel. Thank you.
Thanks so much. Appreciate it. The topic for today is the digital doctor's office, and certainly, as Will said, there's quite a bit of change going on right now. This is an area of virtual care and digitally enhanced care has long been a goal for many of us in the space of healthcare, but frankly, it's not had the progress and the wide adoption that we had all hoped for, or that we had seen the potential for. Now, certainly with COVID and the reality associated with COVID, that has changed quite a bit by necessity, but we welcome the opportunity. We are not letting the crisis go to waste, so to speak, and are really transforming how care is defined and delivered across the country right now. But moving to the panelists, I want to have each one of them take a moment to introduce themselves, share a little bit about themselves, and share about what their company is doing, because frankly, each one of the participants today is an absolute pioneer. Their companies, their work, their efforts have really predate COVID, but are transformative to how care will be moving forward. And so with that, I'm going to just introduce each one of them by name and then ask them to describe a little bit of their background and the companies that they work with and the work they're trying to do. And then we're going to shift toward more of a dialogue, a conversational approach, and have some questions as we move forward. Additionally, there is a chat room there that as we move forward, you can also enter in questions as they arise, and we can address them as a group. So with that, I'll start with Sammy Inkinen. Sammy, why don't you tell us about yourself and the company that you're with?
So very delighted to join the panel. I guess briefly, I'd like to introduce myself. My main claim to fame is that I'm a father of 2 little girls, but relevant to this panel is that I'm a CEO and co-founder of Virta Health, a healthcare company, and we are or have been on a mission for the last 6 years to reverse type 2 diabetes in 100 million people. And I know it probably sounds way too good to be true to say that we are reversing as opposed to managing type 2 diabetes, but we've now published peer-reviewed results and replicated in commercial setting the fact that majority of our patients actually indeed have type 2 diabetes reversed, and most of them eliminate the need for diabetes medications, even drugs like insulin, and we've shown 3.5 year, nearly 5 year sustainability. So indeed, it is possible. Under the hood, as a company, we are virtual providers. So we are like a virtual diabetes clinic. We employ physicians who deliver care virtually in all 50 states in the US. And then the protocol or the actual treatment to achieve the kinds of results that can put type 2 diabetes into remission is really based on a novel concept called nutrition. So very highly individualized nutrition treatments that allow us to achieve these results. And again, it often sounds too good to be true that you could truly take someone who is already using insulin and then reverse the disease and eliminate the need for insulin. But indeed, it is possible. I guess I'll just finish off and say I think the relevance for this COVID-19 pandemic environment with what we do is twofold. One, we've always been delivering care fully virtually, and it's not just telemedicine or episodic telemedicine, but it's continuous remote care. So we touch our patients virtually 2 to 4 times a day. Again, 2 to 4 times a day as opposed to per year. So one relevance is the virtual care, which at the time when touching or being in the presence of other people can be dangerous is very relevant. And then the second thing is, I'm assuming many of your listeners know that, but if you have type 2 diabetes, particularly if you have poorly controlled type 2 diabetes and you come down with COVID-19, the mortality rate is not 2x, it's more than 10x. So more than 1,000% higher probability of dying. So that's the other relevance of what we do. We deliver glycemic control very, very rapidly, in literally in a matter of days. So that's a little bit about me and what we do, and very delighted to be here. So thank you very much.
Thank you so much, Sammy. I really appreciate that. How about you, Dedi?
Hi, everybody. Great to be included in this panel, and thank you for having me. I just hope technically that you see my video. There was a note before that you cannot see me. I hope you can see me now live. So basically, Tyto, I'm the co-founder and the CEO of Tyto Care. We started roughly 7 years ago, really with a mission very relevant to the panel today. How can we make primary care, shift that from physical to digital in a much more advanced way? And really taking the way you all think about telehealth, which is normally online today in the US, to really bring, a lot of capabilities way beyond the video chat or the phone call to make this interaction much more clinically holistic and much more valuable in terms of ROI, both for the consumers and for the clinicians. So we basically created, I think, the first ever platform to really engage a full physical exam remotely. So really allowing patients to do home diagnosis, including imaging of the throat, the ear, the skin, auscultation of the heart, the lung, the stomach, and some basic vital signs like temperature reading, heart rate, and very soon saturation, oxygen saturation in the blood. It's an open platform and a modular device with a lot of AI and machine learning around the data that we collect. So we allow basically any lay user to connect to a clinical group out there while doing a remote visit either synchronously with a clinician on the other side, and Tyto becomes the remote eyes and ears and hands for this clinician, or we can do it asynchronously completely when we, with our capabilities and technology, guide the user or the consumer with a lot of again, algorithms, how to conduct the exam correctly, how to validate the quality of the data, and make sure that the data reaches the physician in a way that they can really diagnose upon and prescribe. We work today with over 100 health organizations, mostly in the US, with some of the biggest health systems in the country and few very large insurers, including Anthem and United. In a big way, we are at scale right now, and we work with hundreds of thousands of patients, conducted in the last 12 months over 600,000 exams and visits with Tyto, and really growing fast and really allowing this use case to happen remotely. We work with general population, but like for the primary care office of the doctor, but also in some more of disease management and RPM modalities for chronic patient, post-discharge, and other, and I can elaborate later. So that's basically us.
Wonderful. That's really, really helpful. Inder?
Hi, everyone. My name is Inder. I am the founder and CEO of Kinsa. We make these products. We make connected thermometers. What is perhaps less obvious is what we do with them. So today we've got a network of about 1.5 million thermometers across the United States that help us advance our mission to curb the spread of infectious disease through earlier detection and earlier response. As far as we and many experts can tell, this network is the only effective leading indicator of COVID-19 spread in the community. In wave 1, it was approximately a 3-week leading indicator of COVID-19 case surges. If you actually looked at our signal and compared it to the New York City death curve, we could predict that 3 weeks out. Yeah. So that's the short of what we're doing is outbreak detection and prediction. And the second piece that some may have seen recent articles on is outbreak monitoring. It's difficult today to know whether policies, whether those are stay-at-home orders or restaurant shutdowns or school shutdowns, are having an impact. You can see that in our data. And at the core of why you can see all this is a very simple public health concept, syndromic surveillance. We do syndromic surveillance. We just do it at the point of inception, people in their homes before they ever talk to the healthcare system. And to the points that Sami and Dedi have already brought up, this idea of being able to go to people where they're getting sick and help them has 2 effects. One is for the individual, but the second effect is that we can now start doing things at a population level that we never could before. The piece of the place that we play that role is in outbreak detection, knowing where and when symptoms are starting, how fast they're spreading, and being able to inform the healthcare system. So obviously it's very relevant today. Thanks for the time. I'm excited to be on this panel.
No, first of all, I'll say each and every one of these companies and these speakers represent, as I said, pioneers. And oftentimes in the innovation space, what I have run into, at least my own personal bias, is it seems like there are technologies or applications that are looking for a solution to solve. That is not the case with what I'm seeing with these. In fact, each one of these has a very distinctive virtue associated with this that really makes virtual care much more virtuous. So with that in mind, I'll just have a few questions that I'll start off. Inder, tell us a little bit more about what the smart thermometer can do aside from taking a temp and storing a temperature on a phone.
Yeah, you might ask yourself, why would someone buy a product that takes a temperature and stores it on the phone? It doesn't just do that. Think of the product much more as a connected medical guidance system that starts with a thermometer, then a connected thermometer. So, you take a temperature, your child comes into your room at midnight. This is a very common occurrence for us parents. I'm sure Sammy can relate to this. Comes in your room in the middle of the night saying, I'm not feeling well. What do? Well, you grab the only product you can in the home. That's the thermometer. That's the only behavior that exists in the home to confirm illness. So you grab the thermometer, you take a temperature. With our product, a minute or 2 later, we would send a push notification. We don't want to interrupt you're taking the temperature, but we do want to help you right afterwards. And so it'll start asking you a series of triage questions. These are widely accepted medical guidance questions. Think of these as kind of nurse hotline on steroids. Asks you, whether you have any severe symptoms. 80% of our users, if they enter a cough, answer a series of 3 to 5 questions to characterize their cough. If you're part of a workplace network or a school network, you can now see the level of health at the school or the workplace. So you can get a little bit more guidance about what's going around. What might I have? So if you see that there's a high level of strep throat, the high level of reports of strep throat at the school, you can now say, oh gosh, it's going to probably be more severe, even though they had early symptoms. Maybe I want to take them into the doctor a little earlier. So that's the utility to the user. But the utility to the community is far greater than that. And that's this idea that the school, the workplace, the health system, the government can now start doing early warning on outbreaks. We get to see mildly symptomatic spread of illness. So let's play that out for a moment. In COVID, someone gets sick. They get a fever or symptoms for a day or 2, but they never get sick enough to enter the healthcare system or see the doctor. They pass it to someone else in the family who's asymptomatic. That person passes it to a third person who becomes symptomatic, and according to CDC, 5 to 8 days later enters the healthcare system. That's the first time the healthcare system has seen someone who is sick. We get to see that mildly symptomatic spread in the household weeks before. And that's the power of this at a big data level for early warning. Today, we've got about 1.5 million thermometers out there, about 4.5 million people. We expect to grow that network by 3 to 4x this year, and that's where hotspotting can be done effectively. I'm going to add one more point, and I think this is relevant to the COVID-19. In any epidemic, in my mind, there's a 4-part response. 1 is early warning. 2 is widespread testing. 3 is treatment and isolation, including contact tracing. And 4 is conferring immunity to the population in some way. A vaccine would be a great way, right? Rather than herd immunity because too many people get sick. What's missing from our public health equation, our public health systems, is a focus on early warning. The way we as public health people are taught, we do not even think about early warning. We are biased towards accurate diagnostic data as opposed to early data that helps us respond in the population sense. There's an outbreak occurring in geography X, send the test kits in, send the virologist in. We don't even think about it. Today, we have the tools to do that, and we need to change the equation, change the way we are thinking about public health, change the way public health people are trained, because there are fundamental basic technologies like the Smart Thermometer Network that have been proven to work with peer-reviewed publications abounding around them. There's 150 different scientists and public health people who have been looking at our COVID-19 data. And we're still not adopting this as a first step in the process. Yeah. My big message is there are technologies today to do profound things, not just for healthcare and the individual, but for public health, population health, and we need to be taking advantage of them.
Yeah, so tell me a little bit more about that. I mean, you have to have been in conversations with, I would think, some of the leading minds in public health. What have those conversations been like, and what sort of traction are you potentially capturing?
There is a group of public health experts and scientists who are huge advocates. And there's a group of public health experts who are more traditionalists who don't want to talk about it. I recently had a conversation with Dr. William Schaffner. Dr. William Schaffner is at Vanderbilt. He's an advisor to CDC. And he said to me, Inder, why didn't I hear about this before the New York Times article came out on it? And I said, Dr. Schaffner, I've been pitching CDC for 6.5 years. I don't know why you didn't hear about it. And, it comes down to this idea, there's another story I'll tell you. There was a state epidemiologist about 3 years ago. We provided a prediction on flu. The New York Times broke an article where we predicted that 2017-2018 was going to be an extremely bad year. 2.5 months later, the CDC changed their prediction and said it's going to become one of the most severe on record. And the New York Times published that article. And shortly thereafter, I was sending a note out to state epidemiologists to keep them informed of what we were seeing on flu that year. And as a reminder, 2017-2018 was the worst flu season on record. There were tents outside of emergency rooms in the Southeast. In any epidemic, you do not want people crowding into a clinic because they're going to spread disease to the vulnerable, right? You don't want that. You want a telemedicine strategy, much what like Dedi and Sammy are talking about, much like what we're talking about. You want that strategy. I remember at that time, the state epidemiologist, and I won't name him and I won't name the state, came and wrote a scathing email back to me saying, fake news, what is this? So I jumped on a call with him and explained it to him. And he said, that's interesting, let me run it by colleagues. And it happened to be a conference held by the CDC. And he called me right afterwards and he said, Inder, listen, you have to understand, we in public health, we don't like being told by a private company where outbreaks are occurring. That's our job. That's the foundation of what we do in public health. He said, but what you're doing is interesting and garnered enough interest that you should stay in touch. So I was encouraged by that conversation because, again, we need to change the way we think about public health. Today, there are 4 teams in the federal government and maybe New York City. Other than those 5 groups, there are not enough public health entities across the country that are funded well to be thinking about new innovative technology. They're not even funded to do that. When you have such a limited pool of people who are thinking about this, who don't necessarily have feet on the street, we're not talking about the local public health entity, we're talking about an abstraction at the federal level in most cases outside of New York City, you need to have better funding in public health so they can be thinking through these kinds of tools and technologies, the adoption of telemedicine, going to people when they're sick. How do I have an underserved strategy when the underserved don't enter the healthcare system because they don't have access to care and treatment? That's where we need our public health officials thinking and thinking about these innovations that can help them accomplish their goals. We need better funding of local public health entities.
That's fascinating. You know, I'm thinking back to one of the other most impactful things that we could do in healthcare to limit the spread of infection. And, you know, that was really discovered by Semmelweis quite some time ago when he clearly delineated that hand washing was impactful to reduction of spreading infection. And now we're, you know, more than 150 years later, still debating and still struggling to get people to wash their hands even now. So hopefully we will change our paradigm a bit to be more inclusive of digital assistance in capturing early warnings without having to wait that long. So wow, that's amazing.
Adam, I'm going to make a prediction here for just one moment. I'm going to predict that in 20 years' time, public health folks will look back at network-connected devices as having a bigger impact than even the vaccine on public health. I'm making that prediction right now because it allows us to go to people when they have a change in health status and help them at that moment. That's the entry point for healthcare. It's not you coming into the doctor's office. So I'm going to make that prediction right now.
That's a bold prediction to go to, because vaccines have been the most effective public health intervention that we have worldwide. That's quite a prediction there. All right, well, we'll see. Now, Dedi, talk to us a little bit about your offering. Essentially, what I'm thinking I hear from you is one of the criticisms at time, or one of the limitations rather, at times, and pushback that we hear from both clinicians and from patients is the relative difficulty of doing a physical exam virtually. Your team really works to mitigate that limitation. Say more about that and talk to us a little bit about what data you have seen as a result of these efforts.
Sure. So as I said, you know, Tyto's mission from the get-go was to really transfer this interaction, this very basic primary care interaction from the physical to the digital. So less about the preventive of knowing in advance, although we do, and I totally agree with Inder, we collect very unique data that can for sure help in predicting pandemics or outbreaks soon. We are not focusing on that element right now in Tyto. We are much more focused on really allowing the clinician to get outside from their four walls and really touch, listen, look into the patient in a much more profound way, in a much more clinical way. So the way we really believe also that it goes back to the topic of this session is that the best people to do that service is not specifically the telehealth companies themselves who sometimes provide the care, but a combination of those telehealth companies with services, but mainly the provider group themselves, the health system. They have the thousands of clinicians already available. They have the clinical brand, and people are coming to them. So we believe really in a hybrid modality when a clinician will see people in face-to-face interaction, but also in a digital way. And we really enable that metaphor. So we basically work in a few use cases, I would say. At home, we really do work in very basic primary care services for families with kids, adults, kids, and so forth, but also focusing on chronic patients and some disease management remotely. We also, on the other side, supporting, I would say, community-based healthcare. So not reaching specifically the last mile of the home. In some areas, you cannot just make it. People have no access or have no capability to purchase the product or to be connected to a system remotely, and they will do, and we supporting them at the level of schools, at level of remote clinics, visiting nurses for elderly population, and so forth. So we really see thousands of point-of-care locations across the country right now using Tyto as a way really to have a hub-and-spoke modality, again, allowing a back-end clinical group or specialist to treat patients effectively remotely. In terms of the way we work, it's basically, again, running the full exam remotely. We do the whole, I would say, continuum of care from symptom checker to recommending of what exams to do, to give insight on the exam on how to conduct it effectively, how to collect the data, how to validate the quality of the data even before sharing to the clinician, and obviously doing the interaction itself. So we are integrated into the workflow of the clinician, whether through Epic or through telehealth company or end-to-end with Tyto, and giving the clinician as part of their dashboard way to either review the data, respond on the data, or even set a session and meet the patient face-to-face over the web, I mean. And in this case, Tyto become a remote hand and ears and eyes of this clinician. Again, as a second layer on that, so this is how we started, and in the last, we are commercializing for about 3 years. It's a very complex product with a lot of regulatory around it, data-wise and FDA-wise. So since we launched, we mainly worked with health systems. And as I said, we are now with hundreds of thousands of patients using the product and over 5,000 clinicians using the system today. And we are now expanding more to, I would say, payer market and risk-taking entities, both self-insured employers and health plans across the country. And the second element of Tyto as we grow is really not only to use the way, today it's more of a technical way to really make this interaction happen effectively online. Now we are adding the second layer of analyzing the data and giving decision support, alerts, some visibility based on the condition of the patient in a much more effective way.
Okay, so to get really granular, what I'm hearing you say is you have devices that connect to or augment through the smartphone or some sort of Bluetooth capacity, and it's otoscope, camera, stethoscope. Say more specifically about what the devices themselves can do and how they work.
Okay, so this is Tyto. It's a connected device to a smartphone. We come with a specific add-on. This is like an otoscope for the ear or nose exam. You just plug it in and it becomes a specific medical tool, all connected and all guided by the same software and by the same experience. So this is a stethoscope for heart, lungs, stomach, and so forth. The product itself also has an examination camera, an IR thermometer, and very soon an SpO2. So we're really capturing all the basic diagnostic data. Most of it is diagnostic, meaning it's unstructured data, unlike temperature or heart rate, which is a number on a scale, and consumer get it. We are dealing with some of more complex information that consumers don't typically know how to do, how to look into the ear canal, how to identify an eardrum, how to listen to the lungs, what is the position, what is the pressure, are those sounds, are artifacts or real lung sounds? So we are helping them in that manner to really bring that to a level of data collection and analysis that usually is being done by clinicians.
Interesting. So imagine I'm a parent. I mean, I personally have 6 kids. So, and oftentimes it was my way of checking a temperature in the middle of the night. If you were to speak to my kids, it was just sort of the back of the hand to the forehead. But grabbing the thermometer didn't really ever fully happen. But if I were not a physician and I had 6 kids, in that situation, I, as a person of means, would acquire these tools and then have the Tyto care in the house potentially. And when I needed or had my kid pull in on their ear or feeling or expressing some discomfort or having a fever, I would then use these devices, communicate with the physician on the other end. They would be able to see the images in their EMR, make a more informed diagnosis, and proceed with treatment. Is that what you're suggesting?
Yeah, basically it is, and the way we are not usually selling directly to consumers, so you normally will get it today in the U.S. out of an offering by your health organization in the area or your provider group. It will be usually recommended by them, or a health plan, insurer will provide it as part of your enrollment like that. And yes, you are right. You will be either connected to that provider group and get the service from them. When you are sick, you will go to our app. You will do the symptom checker. We will guide you about the process, and you will end up connecting to a clinician for diagnosis. But we also see, again, as we grow, more of a consumer-oriented, exactly like you just mentioned, when you are purchasing the device and you have the democracy, I would say, of choosing your provider in your area, so you can see, a service for pediatrics by Cleveland Clinic or by, I don't know, Boston Children's, or you will find, share the data with your own PCP if you desire to. So we can work in both ways. Sometimes, until now, it was mostly B2B2C pushed by the health organization to their patient as part of the service, but we can work both ways.
So essentially what you're saying is it's more, for most of your hundreds of thousands of patients, it's part of their benefit structure as through their insurance or their employer or something along those lines. I'm thinking there's actually, speaking of public health, there could potentially be a public health application for this. You're an international company. You're all across Asia and Europe as well as in the U.S. And so I'm thinking there are a lot of places that simply don't have access to physicians or providers, and that this could be an adjunct to extending care into some of those places where care is less available. So I'm thinking about it from that perspective as well. Now, Sammy, turning toward you for a moment, you recently wrote a piece, publication, where you shared your belief that telemedicine is here for good, but that it won't look the way that it does today. Now, in that post, you argue that the industry will move from episodic telehealth visits to a system called continuous remote care. Can you summarize what you mean from there? What is different about continuous remote care in your mind, and what does the evolution from now to that model look like?
Sure. Well, first, Adam, I have to say I'm still puzzled that you have 6 children and you're still breathing after COVID-19. Presumably, some of them have left your house, so they aren't all running around. But that's impressive. Congratulations.
Let me just say that they never completely leave.
Yeah.
I tried changing the locks. It didn't really work,
So mine might run into the room anytime, speaking of which. So to your question, well, first, I do think that because of COVID-19, the arrival of the future has accelerated by, say, 2 or 4 years in terms of telemedicine. So I do think that, future is here a couple of years sooner than we thought. And in terms of the evolution of how we deliver care and how we deliver telemedicine, in my mind, it's kind of pretty simple. First, we have this sort of episodic care in person. You hop on your horse or your car or your scooter, or whatever people use these days, and you go to the doctor's office. And then, the first evolution of telemedicine, if you will, it was very episodic. It wasn't much more complicated than picking your phone and you call your doctor. So telemedicine in some form has existed for decades, so as long as we've had telephones, I would say. And there's nothing wrong with that to provide episodic telemedicine. And I think that's where we've seen the fastest growth over the last, let's say, even 6 months. So if you need to talk to a doctor, you pick your phone or your smartphone or your computer. But then what is happening and has already happened, and in fact has been the way we deliver care at Virta, at the next phase is what we call continuous remote care. And what that means basically is that we continuously and proactively monitor our patients remotely and proactively interact either synchronously or asynchronously with the patients 2 to 4 times a day. So this is what we call continuous remote care. And obviously, it's particularly applicable to chronic disease patients. Having a type 2 diabetes or cardiovascular disease or any other chronic disease, it's not an episodic thing that shows up once a quarter when you have your scheduled appointment with your physician, whether that's telemedicine or otherwise. It's continuous. People live with the chronic disease 24/7. So that's kind of the next phase, what we call continuous remote care, and that's what we do at Virta. But then there's what I call even sort of the final phase, which is what do you do with the continuous remote care? I think it was one of you in the intro said, maybe it was you, Adam, you said there's a lot of technologists and technology looking for a problem to solve, right? So we can throw all the sensors at patients and say, you know, I have an Apple Watch here. You monitor all these signals, and remote patient monitoring is a hot buzzword these days. We monitor all this data, but that alone doesn't deliver any outcomes necessarily. You know, it's nice to get all this data and use big data and AI, but if you don't have a protocol or something that you do with that, obviously it doesn't really change the patient experience. So I guess to finalize my point, how I see the evolution of telemedicine is, one, it was first episodic. You call your doctor, phone or smartphone. Then it becomes continuous remote care, which is what we practice. And then the last and the final phase is, what do you do with that? And in our case, it's really all about addressing the root cause of chronic disease to try to reverse it. And that's enabled by this continuous remote care. Our providers can de-prescribe insulin on an hour-by-hour basis. We can help with behavior change if we use nutrition to address the root cause of chronic disease. You know, behavior change happens 24/7 as well. It's not, you tell someone, here's 5 things to eat and 5 not to eat once a quarter. You know what's going to happen. 24 hours later, 90% of people have already cut them off the rails. So that's what I think of is the evolution of telemedicine towards continuous remote care, and then ultimately addressing the root cause of chronic diseases with this continuous remote care platform.
What's your secret sauce? What do I mean by that? So what I'm hearing you say that it's, you know, 2 to 4 times a day touches, frequent touches, or is it, how much of it is that component of it, and how much of it is your emphasis on nutrition?
Yeah, well, that's a very good question. Maybe I'll just first mention that secret sauce for what. So I mentioned this in the very beginning, that truly we can reverse type 2 diabetes and put it into remission and eliminate the need for medications such as insulin. And it's been well published and peer reviewed now, and we work with the Veterans Administration on a national basis with large health plans like Blue Shield of California, or large employers, US Foods, Comcast. So we've demonstrated it time after time with thousands and thousands of patients that indeed it is possible. But to answer your question specifically, it's both. So one, the secret source is, without this type of a high touch, high intensity management of patients 2 to 4 times a day, it would not be possible to do what we do. We wouldn't be able to help the patients with their behavior change. We wouldn't be able to safely de-prescribe medications. You take too much insulin and your blood sugar is already down, you know what happens? It's hypoglycemia, and it's very dangerous. So one is this ability to literally hug the patient 24/7, if you will, virtually. And then the second piece is, again, you can do all the monitoring and all the reminders, but if you don't have the right protocol, which in our case is nutrition-based, you aren't going to see those results. So these individualized nutrition protocols is the sort of a biological key to reversing type 2 diabetes. And then technology allows this high degree of individualization. I always use this example of, you know, if let's just say you're a vegetarian by identity or religion, and I tell you to eat bacon and eggs for breakfast, what's going to happen? You lose the patient. And vice versa. If somebody wants to have bacon and eggs for breakfast and you say, let's start with the tofu scramble, what happens? You lose the patient. So you have to be able to individualize to the level of n equals 1. And without technology, that just wouldn't be cost effective. So
you're talking about
both of those things.
Changes on the nutrition standpoint. So if you have somebody that's eating 3 cheeseburgers a day, and the idea isn't to get them to go all the way vegan. It's, can we get you down to 1 cheeseburger a day, maybe some lean protein in addition to that, and sort of make that transition. But if you make those transitions and those habit suggestions and those nudges frequently enough, then you're saying those transitions happen more quickly.
Well, obviously, there are some things that you shouldn't have if you are reversing type 2 diabetes. So not to take the soda companies and sugar here, but let's just say, you know, if we say, you so love sugar, let's just cut off 5%, you aren't going to see the results. So there are some fundamental biological things that are non-negotiable. But you're absolutely right that you have to sort of meet in the middle. And the meeting in the middle is more around preferences, food allergies. You know, we treat truck drivers. They only have access to, you know, the 7-Elevens of the world and fast food restaurants by the highway. But we can literally reverse your type 2 diabetes even if you only have access to a fast food restaurant. But we can't tell that kind of a person to go and buy organic produce and then spend 2 hours cooking. It just doesn't work. We also work with a number of the Native American tribes. So from an ethical perspective, there's a lot of cultural traditions that if we start breaking those in order to achieve health outcomes, we're probably going to fail. So it's more about meeting in the middle while not compromising the science. We can't compromise the science, otherwise you won't be successful.
Yeah, so I hear you, but even 5% reduction, if you do that every day sequentially, in 20 days, you're kind of there. I guess what I'm hearing you all say a little bit as well is that healthcare has traditionally been a facility-based prospect. It has been reactive rather than proactive. It has been come to us where we are rather than we will either meet you physically where you are or meet you virtually where you are. And what you guys have all found a way to provide a solution clearly to meet people where they are, and not just where they are, but when they are being active and pursuing healthcare. So it's kind of an interesting change. One of the things that's become very clear as well is that every one of your devices is dependent on a connection, whether it be broadband or connection to phone. There are large swaths of the population, even here in the U.S., that just don't have access to broadband or to the type of connectedness. What are your thoughts about that?
I'm happy to jump in. So I think you have to look at the type of connectedness too. So we know that, for example, underserved families don't have lots of Wi-Fi. I think there was one study out there that said only 37% of the bottom 20% of folks have Wi-Fi. However, 72+% had access to cellular via their smartphone. Okay. So these populations do have access to a smartphone and do have access to the network via cellular. Now, that's not true everywhere, but it's a large percentage of these groups. And in our experience, when we were giving away connected thermometers to schools, Title I schools across the country, we found that we could get 20 to 25% of those schools on the network. That was actually better performance than even middle-income schools. And they were active at a pretty high rate. 65% of those families were active on a weekly basis, continuous throughout the school year. They were looking for access to healthcare knowledge. 65% weekly active. Remember, not everyone takes their temperature weekly, and this is before COVID-19. So I think there is a thirst for access to healthcare by that community, and I think there are ways to reach them. Not necessarily everyone, but a very, very large percentage of them, if you consider the smartphone as one mechanism to communicate.
Thank you. There's a question specifically directed to Sammy. I will take a first step at answering it, but I'd love to hear Sammy's thoughts. Sammy, will physicians be paid for continuously remote care if you have frequent touches daily? Is the bill rate affected, meaning can you get paid for continuous remote monitoring, and does the amount of the monitoring change the reimbursement? My understanding is that at least for most of the payers in the United States, at least, it's a monthly prospect that if you have substantive monitoring that leads to clinical decision making, you can drop a charge for that on a monthly basis. But I'd love to hear what your thoughts are.
Yeah. Well, it feels like it's a softball question for me to promote our outcomes. And I say this because I actually made the fundamental decision in the very beginning when we founded Virta that we are here to make patients better. Diabetes is a massive problem. A lot of people making a lot of money out of the problem, but it is not going away. And if anything, we are just maintaining the status quo. So we said, you only pay for results on an individual patient basis. So our business model actually takes the fee for service completely out of the picture. If we don't reverse type 2 diabetes, we don't deliver results, we get paid zero. So we economically, we work with health plans, again, such as Blue Shield of California and dozens of others throughout the country, large employers, self-insured, and then also the U.S. government, such as the Veterans Administration. So we go to them and say, well, diabetes is a big problem, isn't it? Yes, it is. Would you like us to help to shrink the problem, and you would only pay for results? So our economic model is really, it's basically an outcomes-based fee with 100% of the fees at risk. So that's how we operate. Now, I don't know who asked the question, what background that person has, but at the same time, CMS has been pushing different remote monitoring fee-for-service CPT codes in order to promote remote monitoring in general. But again, we philosophically as a company, like I said, sometimes there's technology looking for the problem to solve, and there is a danger when you give billing codes and you're like, hey, let's just throw a bunch of devices to people so we can be charging whatever the number is, $40 a month. We say, we do all that work. If you don't see results, you don't pay. So that's the approach that we've taken.
No, I like that. Thank you. Inder, back to you. Kinsa has shown a clear ability to detect COVID-19, and it spread early on. Really, what needs to be done for this data to be used more readily and more effectively? It sounds to me like if we were using some of this type of data more readily, we'd be able to impact the outcome of this disease. What are your thoughts about what are the barriers to that, and what would be next steps to overcome those?
Yeah, I don't want this data just to be used for research projects, and there's a lot of research going on today. We don't have time to do more research, and there's already a bunch of peer-reviewed publications out there, so there is some strong scientific basis here. A number of senior scientists have looked at this, and I think it's important to be used. I can't tell you. I think, I'm struggling because I want to make sure that we have a public API for public health agencies to adopt it. Again, I think a lot of research is going on, but we really need to start using it. And I think part of my job, which I need to do a better job of, is bringing more people into the fold, more scientists, more public health people who've looked at the data, who've scrutinized it in depth. We're starting to build that group up. There's a lot of people in public health and science that are really busy right now. So we're trying to bring more and more people into the fold who can stand up and say, it works. Why are we not doing it? I wish, again, it needs to be used, and I'm trying to do everything that in my power to help bring that to bear. If there's folks out there that have influence over public health and how they're using early warning and want to do a deep dive on this stuff, please reach out. We'd be delighted to share whatever information we can with you so you can vet it yourself. But that's what we need to do today.
Thank you. Dedi, I'm directing this next one toward you. All of, so much of this connected care, this virtual care that uses connected devices, one of the criticisms or challenges associated with it is, how do you maintain the human connection, the sort of person-to-person connection throughout this digital experience? Any thoughts that you have about that, or any best practices? Because after all, this is a person working with another person, albeit remotely, to try to help with their healing and their wholeness. So what's your experience been with that, and what would you suggest as some potential best practices to keep the human connection into these virtual connections?
Sure. So I would say a few things. First of all, a lot in healthcare is around the psychology. And I think part of the barrier starts with people believing that this care model from the consumer side is meaningful and will provide, enough of value for them. It's also from the clinician side, but it's mostly from the consumer side. And if you look at numbers, and let's be honest, the telehealth prior COVID was maybe 2 to 3, 4% utilization. Most of the utilization out of those 4% came from mental health, okay, which is relatively, relevant for video conferencing or for a telephone. So there was not too much adoption. Now with COVID, everything is off the charts, and we are seeing an amazing growth as well, and everybody is doing that. We know that right now It's obviously everything is expediting very quickly, but it's not the new normal. It's going to go down, probably not to the same level. And still the main question becomes about the connection between a physician and a patient is the level of trust, first of all. And I think from our perspective, what we learned is the more you can use your own clinician or a trusted provider group, that eliminates a lot of the barriers. The fact that you can really do something meaningful like a remote exam, it doesn't matter if it's Tyto or something else. If people feel that now their kids, I was using, when I started Tyto, it was out of a personal need. I still have, obviously, two young kids. Now they are older. And I consider myself a tech person. I had a free, zero copay services in Israel before I moved to the US. I never used telehealth. And the reason was that my wife said all the time, if my daughter is sick, we know that she had an ENT issue, throat and ear infection constantly, and she wanted the physician to look into her ear or to listen to her lungs. So this was the main barrier for us. So I think one, if you can have the tools that people feel, and I think the pandemic right now raised the awareness dramatically, so people are now much more open to look on solution like that. We see that on a day-to-day basis with the amount of traffic and the amount of demand that we see. But so it starts with that, but also connecting to a trusted provider group is also very meaningful. Some of the limitations that we saw were that you are connected to an anonymous clinician. Sometimes you will not have the continuity of care in primary care, and you do want that. It's not like taking an Uber drive when you don't really know who's the driver. You don't really care because you will probably not see him or her anymore. In healthcare, it's different. So I think those two elements are barriers. And, beyond that, you will always, if you can do an online, a physical interaction, that's obviously the best if possible. But in today's world and when people, in terms of distance and time and the weekends and the, transportation and the cost, it's just not being so effective in most of the cases. So I believe there's a room for both. And as we make it, telehealth or online care much more close to the face-to-face interaction in terms of the trust and in terms of the connection, that would be the best.
Thank you. Now we're close to wrap up here in just a moment, but I'm going to go person to person to give each one of you a chance to make maybe 30 seconds of a closing comment. So I'm going to start with you, Sammy. What would you like to say in 30 seconds?
Well, the arrival of future has accelerated by 2 to 4 years in terms of utilization and use of telemedicine and the new ways of delivering care. And we are not going to go back to the past when COVID-19 is over. So I feel very strongly about that. And I think that is one of the silver linings of COVID-19. And it is a good thing for our society and patients and everyone involved in healthcare.
Thank you for that. Dedi? 30 seconds.
Yeah, sure. I totally agree with Sammy. Things will not go back to what it used to be. I think the era of making that part of the care delivery model has arrived, and health organizations fully needs to change the way they're providing care. I also think in my small prediction is that data-related analytics will take the second wave, of expanding those services, and without data, there's nothing. I think this is the next wave anyway for progressing that.
Thank you. And back to you, Inder. 30 seconds. What are your thoughts?
I'll make 2 points. One is the success of these kinds of telemedicine tools will be directly dependent on an amazing user experience for both the end user and the clinician and provider. And we need to make sure user experience is great for both in order to take advantage of these devices on an individual level. The second point I'll make is it's not just about better care of the individual. It's about better care of the population too. With a network of these devices, we can do things that we've never imagined in the past, like real-time detection of outbreaks that can help us contain them when they're aflame before they become an inferno and save lives and livelihoods.
Thank you for that. Wow, I'll tell you, all of you have given us plenty to think about. And I want to thank each one of you for the innovators that you are. And again, the innovators that make a difference and are making real impact for the health of the world, frankly. So thank you for that. And thank you for the opportunity to get to know each of you just a little bit and for the opportunity to interact. And I look forward to seeing the fruit that come from your efforts. And so with that, I will turn it back over to Will Morris and to take it home. Will?
Thank you very much, Dr. Myers, and what a tremendous, enriching panel. And I would share the degree of optimism, hope. It is about time, and we need to execute. With that, actually, we segue into our next panel, August 11th, and we kind of addressed it. It's healthcare's latest sidekick, needed sidekick, which is AI. So we talked a lot about data in this new paradigm in which we acquire lots of data, but how do we actually transform it into insights? And so we'll be discussing with leading innovators, both healthcare delivery payers, but also technology companies of their predictions, their strategy in bringing value in transformation, leveraging artificial intelligence and machine learning. So that'll be on Tuesday for Transformation Tuesday, August 11th, 2020 at 1 to 2 p.m. In addition, for those attendees, feedback is the most precious of gifts. We will be submitting a survey, and we look forward to hearing your feedback, ideas for both this presentation and ones to come. Again, it is my humbled honor to thank you all for spending the time, and we look forward to seeing you back in August. Stay safe and wear a mask.